Uh, Thank you so much for the organizers to accept us to present results from this study, disparity in hepatocellular carcinoma screening and its detection rate in individuals with hepatitis B or C and cirrhosis in Canada. My name is Damascene Makuza. As I said, I'm from University of British Columbia School of Population Public Health. I'm here representing the group from BCCDC, which is here. Before presenting my presentation, I would like to acknowledge that this study was carried out and assessed in ancestral territory of Costa Rica people, including territories of Miskoum, Squamish, Tororo, Cirrhosis Nation. I also acknowledge that the land of which we get is the traditional territory of Huron-Wendat, the Innu, and the Wanabak peoples. This disclaimer. Hepatocellular carcinoma is a leading cause of mortality globally and in Canada. As you know, the literature says that hepatocellular carcinoma is the seventh most common cancer worldwide and the second most common cause of cancer-related death. Recent data in Canada shows that the incidence of hepatocellular carcinoma is about 6.5 per 100,000 of individuals, which is higher in North America. And also, it shows that about 3,000 of individuals in 2019 were diagnosed with hepatocellular carcinoma. Different studies which were conducted elsewhere, like in Korea and Japan, have shown that regular hepatocellular carcinoma screening is effective in detecting early-stage cancer and improving survival outcome, particularly among individuals with liver cirrhosis due to hepatitis B or hepatitis C. There is limited information on disparity in hepatocellular carcinoma surveillance and detections. As you know, one of the components of WHO goal to eliminate viral hepatitis is to prevent mortality up to 65% by 2030. So conducting this study could help in getting people or getting some gaps in the screening hepatitis C, hepatocellular carcinoma, and then getting them should look for a solution so that we can get those individuals who could die from hepatocellular carcinoma and maybe treat them early. We aim to identify gaps in care by assessing disparity in HCC screening and detection among people with hepatitis B or hepatitis C and cirrhosis in British Columbia, Canada. We use this dataset, which is a BC HCC, containing information of individuals who were tested in the public health laboratories of BC for hepatitis B, hepatitis C, and hepatitis and HIV, and also some cases reported in the public health of BC containing hepatitis B, hepatitis C, HIV, active TB cases. And this dataset is linked of different administrative datasets, including prescription drugs, hospitalization, medical visits, cancer, vital statistics, emergency department, and the other chronic disease. This dataset contains about 1.7 million of individuals, and among them, we have about 72,000 of individuals who had chronic hepatitis C. We included in this study individuals with hepatitis B and hepatitis C or hepatitis C diagnosed with cirrhosis between January 1990 and December 2020. And the study outcome include hepatocellular surveillance and hepatocellular detection. We assess also factors associated with HCC screening and detection, including social-demographic characteristics such as age and sex, ethnicity, material and social deprivations, as well as comorbidities, including diabetes mellitus, end stage of renal disease, and injection drug use. We estimated the prevalence of HCC screening and detection stratified by hepatitis B, hepatitis C status, and by a number of healthcare visits during 1 year post-cirrhosis diagnosis. We used multivariable logistic regression model to investigate factors associated with HCC screening and detection. This is the population flowchart, which helps us to select a patient or individual who were retained in the final analysis. And we had about 14,000 of individuals who have been considered for the final analysis. And the majority of them were mostly those people who had hepatitis C monoinfection. Among the study population, majority of them were males born between 1945 to 1964, baby boomers, and from other ethnicity than East and South Asian background. And the majority of them were having the compensatory cirrhosis. And about half of individuals visited the health facility over 25 times post-cirrhosis diagnosis. As the outcome, we found out that in general population, or in the study populations, about 52.4% were screened for HCC, while I think the high proportion of individuals were screened among those with having HCV, chronic HCV monoinfection. On the other hand, we found out that among those who were screened for HCC, about 11.8% were detected with HCV, and the high proportion of individuals who were detected with HCC were among those individuals having co-infection, hepatitis B, hepatitis C. In multivariable logistic regression, we found out that individuals who were born between 1945 to 1974, compared to those who were born before 1945, individuals who were having diabetes mellitus were more likely to be screened for HCC, while individuals who were males and the individuals who were having a history of injection drug use were less likely to be screened for HCC in the whole population, the study population, and also across different study groups. We found out that those individuals who were having hepatitis B and treated, and those who were having hepatitis C and treated, were more likely to be screened for HCC. In addition to that, we found out that those individuals who were from East Asian background were less likely to be screened for HCC among the total study populations and among those people who are having hepatitis B. Considering factors associated with HCC detection, we found out that in the multivariable logistic regression that males individual born between 1945 to 1964 were more likely to be detected with HCC, while among individuals who have a history of injection drug use and those having diabetes mellitus were less likely to be detected with HCC in the whole population and across the different groups. In addition to that, we found out that people from East Asia and South Asia in the total general populations were having, were more likely to be detected with HCC, as well as individual having hepatitis C. Stratifying our study population by number of healthcare visit post-cirrhosis diagnosis, we found out that as the number of visits increased, the proportion of individuals screened for HCC were increasing too, which was different for HCC detection, which we didn't find any difference between them. This is a crude one. In multivariable logistic regression, we found out that in different strata, we found out that in people or individual with history of injection drug use were having disparities among different groups, even increasing the number of visits, as well as among individuals who were males. As key findings, our study find out that HCC screening among individuals with cirrhosis and HCV or hepatitis B was low, and the prevalence of HCC among individuals who were screened were high overall, with highest prevalence seen among those with co-infection hepatitis B and hepatitis C. Male sex, history of injection drug use, and East Asian ethnicity were inversely associated with HCC screening. Both HCV and HBV treatment were associated with screening, as we saw that those who were treated for HBV among those having hepatitis B and those treated among those who were having HCC were more likely to be screened for HCC. Even when stratified by frequency of healthcare visit, despite in HCC screening persisted among those with history of injection drug use. To conclude, there is significant disparity in HCC screening and detection by birth cohort, sex, ethnicity, history of injection drug use, and healthcare engagement. Enhanced surveillance is needed for high-risk groups, such as people of East Asia background living with hepatitis B, people with history of injection drug use, and those with limited healthcare contact. Hepatitis treatment presents opportunity for improved screening. We suggested research to investigate barriers to screening in high-risk group and evaluate intervention to improve surveillance. By this, I would like to thank different institutions which supported this study, and also acknowledge the contribution of different individuals in our group, co-authors. And thank you, all of you, for your kind attention. Thank you.
All right, I'm being told we have time for one question.
Hi, thank you very much for a really interesting talk. Two questions. I noticed that the proportion of hepatitis B patients who are HepC co-infected was very high compared to every other cohort I've ever seen. So I'm wondering if you had any insights into that. Second observation was diabetes was actually identified as having lower detection of HCC. Historically, diabetes has been identified as a risk factor for HCC. So I'm wondering if you have any thoughts about that.
Yeah. Yeah, that's a good question or good observations for individuals who having diabetes who were less likely to be to be detected with HCC. I can say it is not easy to respond to that questions because it needed to maybe to go into maybe more research and to detect if to look at if diabetes could influence that hepatocellular carcinoma. Because with research I conducted, I tried to look at the literature review. Individuals with diabetes were not seen among those people who can develop maybe hepatocellular carcinoma. People I saw males individual and maybe other individual, but not those people who have diabetes mellitus. I think we need to conduct more research about that one, maybe having more people, a number of people which are high, but at this moment we didn't find it. Yeah.
What about the first question? That's my question.
So, so then why you see more co-infection? Because this is a population-based cohort. So the other cohorts that you have been looking at within Canada are just based on selected population. So you have a very large population that has hepatitis B infection, mainly of East Asian origin, and then you have Hep C as well. So that's where like you have a pretty decent number of people with co-infection as well.
So are you defining co-infection as just anti-B core positive, surface antigen negative?
No, so this is based on surface antigen positivity. Yeah. And there were some data that we presented a few years ago at ASLD looking at the sequence of infection and mortality related to co-infection and so on. So we could share that with you as well.
Okay, thank you very much.
Yeah.
So our next speaker is Andrew Medwitz.